Good afternoon. Susan, just checking my audio. And
Loud
I
and
see
clear.
see all the board members. Dr. Foster, how are you?
Good to see you, Chair Foster. I'm doing well.
Good. And you have everyone you need?
I do, yes.
Great.
Hopefully you can hear us okay.
Just fine.
Great.
Right. And do we have a court reporter for this afternoon?
Let us confirm that, Chair Foster, I know we do. We just need to make sure they're on the line.
Okay,
Thank you.
sure. Give it a minute. I apologize. I think we're gonna have to delay 10 minutes. There seems to be an issue with the court reporter, so we're gonna check into that. So we'll start. Susan, is that okay?
She's
sorry.
in the process of joining right now, so it'll just
Okay.
take like 2 minutes.
Perfect.
Okay.
Yeah, I'm on the phone with
Thank
her.
you, Abby. Okay. So
Thanks,
do you want
Abby.
to stay on, Owen, or just take a quick recess?
We can just stay on and wait.
Okay. Apologies for the delay here, gang. Thank you for your patience.
No problem.
Getting in my daily meditation.
Just builds the anticipation for your opening remarks.
That's exactly right. We're excited to have the opportunity.
Everyone's waiting with bated breath now.
When you're first out of the gate and you're new as a CEO, you're not sure what to expect, but I know this will be a good dialogue.
Thanks for waiting.
Chair Foster, it looks like the court reporter is in.
Good morning. I am here. I am just going to call in with my backup right now, just to make sure we have excellent recording.
Great, thank you. It's Miss Vasquez?
Yes, that's me.
Miss Vasquez, whenever you're ready, just let us know, okay?
Yes, it says I'm joining now. I'm just waiting to be let in.
There shouldn't be a lobby. Is it this same meeting?
Yep, it actually just logged in as soon as you said something.
Oh, great. Okay.
And then I just have to confirm my speaker. Just give me 30 more seconds. So sorry about the wait. Okay, everyone can hear me okay?
Yes.
Okay, and I can hear everyone else okay? I am ready to take us on the record when everyone else is.
Okay, great, thank you. We can go on the record.
Okay, we're on the record.
So we will resume the Care Board's hearing of August 5th. Next, we have a presentation by Mount Ascutney Hospital. I'll ask our counsel, Mark Hengstler, to swear in the witnesses, and then Dr. Foster, if you could introduce yourself and the team after Mark does that, and then we'll listen to your presentation. Thank you very much for being here.
Good afternoon, all. I'm going to ask that anybody who is going to be testifying for Mount Ascutney go ahead and raise your right hand. I'll read the oath administered to witnesses, and I'll ask you to say I do after I finish. Do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalties of perjury?
I do.
All right, witnesses are sworn in.
Thank you for the opportunity. I'll introduce myself. I'm Dr. Matt Foster. I'm the president and CEO of Mount Ascutney and the Valley Regional Hospital. To my left.
I'm Andrew Garamy. I'm the Director of Finance at Mount Ascutney Hospital.
And I'm Celeste Pitts. I'm the interim CFO.
We appreciate the opportunity to speak with you today. We have a brief presentation, but importantly, I want to take the opportunity to introduce myself to you all on this team. I've had the pleasure of talking with Sheriff Foster in the past, but some of you may not know me and hopefully get to know me and our approach to the team. You know Mount Ascutney, but also the opportunity for us to engage in dialogue. And hopefully this will be a brief presentation with questions and answers and plenty of opportunity because I'm sure you have questions. So if we want to go ahead and we'll start. Hopefully you can see the slides. I don't know if it's in presentation mode or not, but it looks like it may or may not be.
Interesting. It is for us on my computer, but not on the screen.
It's up on our screen.
Okay,
Where is it? Okay.
Okay. In the interest of time, I think too, first of all, I just want to say a couple words about me and our approach and this budget is that I firmly believe in the power of collaboration, consensus, and community. Healthcare is a team sport. And that means we will be stronger and more effective by working together towards a common goal of ensuring access, affordability, quality, and sustainability in healthcare for all Vermonters. And I mean that sincerely. I've been a CEO of Mount Ascutney for 8 months, but I've been a physician for 29 years. And throughout my career, my core principles remain focusing on putting patients first and working in the service of others to ensure high quality care for the community we serve. My entire career has been serving rural communities, and I've seen the unique challenges of rural healthcare delivery. And I believe access to high quality care locally is not a luxury, but a necessity. I believe our budget frames those core values. Here in Vermont, we have a duty and obligation to seek and ensure a viable, sustainable path forward. The people of Windsor, the surrounding communities depend on Mount Ascutney to be there as a trusted partner to ensure their health and well-being, and we will be. Are you seeing our slides advance? Because we're seeing them here, but on our screen, we're not seeing that. I just want to make sure you see the slides advance.
I have not seen the slide advance. I'm still on the intro slide.
Give us a second because we should be on the third slide.
Oh, there we go. Got it. We're on 4. I see facts and figures.
Okay. Yes, that's correct. Andrew, do you want to see if you can figure that out a little bit? Or do? Okay, we're going to see if we can get that and bear with us for a second.
At least this year you could see us.
Yeah,
Last year I
last year
think
you
we
could
had
see us.
even worse technical.
There we go. That looks
Oh,
good.
back. Okay, great. And so, well, I don't want to read this because I think people who read slides typically it's because you're trying to put them to sleep and I really want this to be a dialogue, but I do want to highlight a couple things. First of all, is there a way to get rid of the stop sharing? Really, because it's importantly, the 20,000 meals we provided through Meals on Wheels, that's through our kitchen and historic homes are running that serves this community. That's something, a service we provide. The 35 residents of historic homes, majority have Medicaid, is a service that we provide that may not necessarily be reflected in the acute visits or the shared services that we have with our rehab and our acute hospital, but is incredibly important to these communities. And also our community health team and the 6,000 children and family and community members that we help and support through the wide outreach they have that I'm really proud of. And hopefully now it's advancing. Some of this work I know you already know, but I really want to highlight too because our core values are the care that supports our community. And looking at our population and what that population is and who we serve helps to inform the kind of care we should be delivering. And what we're going to do, we want to do well and we want to do it appropriately for the right reasons. Also taken from our community health needs assessment, and I highlighted this because I think it speaks to some of the challenges in rural healthcare, and specifically also in Windsor, and that is the number % of family households with children headed by a single parent, and what that means for the activities of daily living, social determinants of health, and access to healthcare. You're a single parent trying to get your child to a doctor's appointment. It may be taking time off work. It may be transportation issues, and a lot of the challenges, the stresses that come with that. And I'll highlight that story in a second with the second and third generation care. But these are the challenges that that all hospitals in Vermont face. But I think it's paramount to our mission of the communities we serve, and to be there for them in ways that make sure it's meaningful to them, not just in ways that necessarily serve the interests of a few, but are really healthcare. In many ways, we really are the safety net, and I think that's true for so many critical access hospitals in places I've worked, but also certainly here in Vermont. But it's not just access to care, it's access to assistance, particularly now as we look at some changes in the federal Medicare and Medicaid requirements. Navigating the health system is complicated, and many individuals will not be able to enroll in services without assistance. And we're proud of the assistance we provide, staff and experts, that when they come in for a pediatric appointment, can ask them about Medicaid and Medicaid enrollment. It can help and find the necessary services they need at the time. With our mission to really improve the lives we serve, and it's not just about in the four walls of the hospital, it's beyond that in the communities we serve. I'm proud of the fact that we personalize care for our community, and I felt it's important as a physician to tell a patient story. And I know this will sound familiar to many of you, and it is not necessarily unique to Mount Ascutney, but I think highlights the care that we pride ourselves in. And that's a patient, and for sakes and purposes, anonymous, we'll call her Emily. She's a 16-year-old who came in for a well child visit. She was complaining of tooth pain. She was brought in by her grandfather because she was raised by her grandmother and grandfather. Her grandmother had just been discharged from the hospital in Dartmouth and it was now oxygen dependent. It was the middle of winter. She had tooth pain, and turns out she had a tooth abscess. She was also had a thyroid problem. The grandfather, Rodham, had a migraine and was complaining of headache and severe headache. And it turns out they didn't have heat, and they needed fuel assistance. So at the time of the well child visit, not only did they find fuel assistance for the family, they made sure that she was connected to a dentist, made sure that she got connected to local care for her thyroid issue, all of which was done here, and then arranged telehealth access so that her grandparents didn't have to travel when they had their own health issues, as well as providing holiday gifts. It's this type of care that we provide when it could have been a 20-minute well child visit that's not reflected in productivity. It's not reflected in work RVUs, but it is reflected in the care that we provide to our community. I think it's really important to keep that in mind when we think about access, we think about affordability, we think about sustainability, we think about quality. We're really proud of what care we can provide here. And it's part of being a community. It's part of what it means to be in a community, is being in a relationship with people, getting to know people, and taking care of the entire patient, not just focusing on one problem, one disease, or one work RVU. So again, taken from our community health needs assessment, and this is what it helps inform our budget. And it may not seem at first glance like that's the approach but I think it's really important, as we talked and I talked to our finance team, of taking our community health needs assessment and saying, what is it that we need to provide? If there's not enough local capacity, how do we increase access? What do we do without increasing costs, without increasing expenses beyond what we can afford, to make sure that we ensure access, that we have the right navigators, we have the right support to help people in our community navigate the health system, that we help to provide and support transportation, those basic needs of health. These are all fundamental to what informs our budget. This slide, if you've seen before, we made question mark, and I put this in here because I think it's a really important slide. And what I want to highlight is a couple things. First of all, when you're thinking about every action has an equal and opposite reaction, that is certainly true in healthcare, and it's something that we think of every day. When we think about budgets, we know when we have a tight and narrow operating margin, we have difficulty with reimbursement, and costs are rising, and the challenges in healthcare feel unrelenting, that every decision we make is going to have an equal and opposite reaction, and it has consequences. And so we're really thoughtful and careful about that. So when we look at this, and I pulled this data because I think it highlights a story. And if you look at the red in October and in December with the overall hospital rating, and then you look up at the top when you see some increases in patient falls with injury around the same time. We had 2 falls with injury. When we looked in October, December, and November, we had a higher incidence of travel, which is a high incidence of temporary employees, both of the nursing as well as in some of the support staffing areas. And they weren't necessarily poor quality, but it's that sense of continuity of care and part of the teamwork that impacts when you have a high patient census in the inpatient world, and don't have necessarily the attention you need in and I'm not trying to say causality, but I do think there's a correlation here between the staffing ratios, the staff that we have, and safety and quality. And I think it's important to tie that in there as we think about reducing costs, think about being more efficient. We also need to make sure that we're maintaining high quality, because when we don't, things like this can happen. As a pathologist, I felt it important to also understand that we can look under the microscope, and we can look very, very narrowly at a very high power, and we may miss the bigger picture. And so I think sometimes you have to go back to a lower power picture to see. And one of the wonderful things about a microscope is you see things in a different lens, and you see a whole different that you couldn't see when you look really close and magnify things. Sometimes that's appropriate. Other times they're probably just step back and go, what are we trying to do? And in this case, I think with our budget, what we're trying to do is to maintain access, to maintain affordability, to maintain quality, and to maintain sustainability for the long-term future. So I think to that, I just want to highlight before we get to the current year review is that we do focus a lot of attention on affordability. When we talk about affordability, we have to consider the total cost of care and what Vermonters actually pay out of pocket for premiums, deductibles, and copays. The costs of care have outpaced wage growth. Insurance deductibles, premiums, copays are unaffordable for most and force people to delay care or skip medications. We recognize that the current path is not sustainable. We cannot continue asking Vermonters to bear premium increases that outpace their pocketbooks. Affordable healthcare is not just about cutting costs. It's about innovation, prevention, investing in primary care, and community health. We believe that our budget signals that we are doing our part to ensure affordability. This year in particular, we have had a change in corporate structure. Valley Regional Hospital in Claremont became part of the Dartmouth Health in July of 2024. They hired a CEO, that's me, to run both of those hospitals. We created a mirror board that is now a joint mirror board of both Mount Ascutney and Valley Regional, with the fiduciary and community responsibilities of a board for these two hospitals. We've had additional changes as well as a shared CEO and shared CFO. Leveraging the systemness of Dartmouth Health means that we have the ability to realize some of those shared savings, particularly when it comes to IT integration and going on to the EMR, Epic EMR later this year. Our corporate structure, again, will be familiar to all of you with the exception of the Valley Regional, which has joined this year, and also highlighting that Historic Homes of Runnymede is part of the Windsor Hospital. And I want to highlight just briefly, because Historic Homes is an important mission for a part of Mount Ascutney. We have 35 residents. Almost 70% of those are on Medicaid. We historically have functioned at a break even, and we're perfectly happy with that. Last year, we realized an operating loss, and we expect that to continue. These are historic homes, 1796 when the first home was built, which means that they have the charm of an old home and the challenges of repair of old buildings. A now 3-year-old assessment said that probably close to $2 million estimated repairs are needed, and that's not just life safety issues which have been addressed, but structural long-term needs for buildings to ensure that they're sustainable and stable. Given those challenges, we reflect that in our budget as something we wanted to highlight because it's something that we believe is an important mission to people and residents that may not have another place to go, and that it also helps to serve the Windsor community. Finally, I think just to address some changes in service lines, we are committed to providing care. And part of the strategy of what we're going to do is highlighted here is thinking about ourselves as a system. How do we leverage the systemness of being part of Dartmouth Health to increase affordability, increase access, to think through how we can collaborate together, how we can integrate. And the root word for integration is integrate, which means to make whole. So how do we make whole the care that we provide in our community? We want to focus on affordability. And we're going to choose what we do. And what we do, we're going to do it well. We're not going to do it just to do it because we can. So we think about neurology, where we've been able to increase access and double the weeks that we have neurologists on site. It is still a locums position, which is expensive, and we're looking to see what we can do to decrease that expense by partnering with Dartmouth Health to provide that service. We've just hired in behavioral health. We've just hired a new psychiatrist, and are looking to hire a new nurse practitioner because we know that there's a need in this community, and we want to be able to offer behavioral health services locally. oncology and pain, we are no longer doing, not because it was a deliberate choice, but because as single fault tolerant, when physicians leave, it becomes harder to replace. And now it becomes a question of, should we be doing that? And if we choose to do it, are we going to do it well? That's an ongoing conversation, but it's currently a service we do not offer. I think important to highlight the general surgery collaborative and thinking what it means to integrate it and to make whole. To say, how can we collaborate with our other affiliated hospitals in our health system, as well as in Vermont, to provide general surgery coverage? We have general surgeons here. Do we have to be independent and have our own that only work here? Or how do we share and collaborate across state lines and across other hospitals in Vermont to make sure that patients can get the right care at the right place at the right time? We're also proud of ophthalmology. We think we can do that well at lower cost and provide non-operative care and outside an academic center that's a setting that will lower cost. I also want to highlight the walk-in hours. What we've seen is in prior hearings, you may recall, we talked about having walk-in as a way to decrease utilization. What we have seen is exactly that, is that instead of coming to the ED, patients are choosing to come to walk-in. And so we've expanded that from 4 hours to 8 hours. And we look to thinking about how we can expand that to working hours that are more convenient to those working parents and people that might have to come in the evenings or on weekends, because we know, having evidence, that it will reduce our ED visits and therefore reduce costs. And we believe that's a really important advantage for having people local, rather than when they need care on a weekend to have to drive to a place that may be more expensive, is when they can do it here. And finally, a couple of variations of budget before we change. I shifted over to Celeste and the finance team. I think it's important to highlight that we, as part of the government health system, we are seeing more acute patients as we think about acute to acute transfers, which we have. I'm proud of the fact we have the capability and skill sets to take care of those patients well, but also requires more resources. And what we've seen as we started that is that our revenue has been below budget, primarily because of the resources needed to take care of sicker patients, as well as a shifting in payer mix. I think also, and I want to highlight that our expenses have been below budget in many categories. And I think that's something to examine and look at. As a consequence, I think we're going to have a challenge hitting our budget this year. And I think, as we think through some of the headwinds that we're facing, I think just the reality is, even though we have a narrow operating margin, it's going to be difficult to finish that. And so finally, before I turn it over to Celeste, I just want to highlight a couple of things. We recognize that rising healthcare costs mean people delay or avoid care until they have an emergency or have no choice. I think we can do better. Healthcare costs are not just a line item, they are a daily concern for all of us. They are shaping whether families can stay in Vermont, whether small businesses can continue to operate, whether employees can offer benefits, and whether our hospitals can continue to serve the communities that depend on us. It is a shared concern, and we must all be part of the solution if we are to address this crisis. The team at Mount Ascutney believe this, I believe this, and I know you all do too. It is a shared concern, and we must be part of the solution. I believe our budget, as submitted, is directly in line with this goal, and I'm very proud of the fact that we submitted a budget that hits the targets for the things within our control and aligns with our mission, serves our community, ensures a sustainable path forward, and always push patients forward. For expenses out of our control, we're asking for an exception, and I'm hoping this board will see, recognize, and acknowledge that we have hit the targets for that which is within our control, that we demonstrate to you that we presented a budget that is responsible, that aligns with our shared goals and the principles for healthcare reform. And you will clearly see our commitment to do our part to ensure access, affordability, quality, and sustainability for all Vermonters. It is a profound and deep privilege to have the opportunity to lead Mount Ascutney, the nurses, the physicians, and other providers and staff, and also serve this community, particularly in this pivotal moment for healthcare. We can do this together. We are stronger together. We are resilient, and we are committed. Thank you. Now I'll turn it over to Celeste as we'll talk about some of the more details of the budget submission, and I'm happy to answer questions.
Thank you, Dr. Foster, and thank you, Green Mountain Care Board. Yes, can everyone hear me all right?
Yes.
So our principles as we pulled the budget together this year were to stay as close as possible to the guidelines set by this board, while continuing to align with the needs of our community. Oh, thank you. We met the first two, which have been goals for a while. We struggled with the operating expense. the operating expense goal. As Dr. Foster noted, we have asked for 3 exclusions. If we have those granted, then we will meet the 3% expense growth. Next.
Sorry about that. There's a lag. I knew it wasn't a lag when I was advancing. I don't know why.
Okay.
Yeah.
So here's just a summary of our 2026 budget with a comparison to our submission from last year. Move on to the next. So the next slide, we'll talk a bit about what does a 3.5% NPR cover. I'd like to start with the second one, the salary increases. As Dr. Foster pointed out earlier, there is a direct correlation between staffing and quality. This increase builds on the progress we've made, bringing our staff to market and reducing our reliance on travelers. Out of the 3%, 2% will be a COLA increase for all staff. The remaining 1% will be a market increase, which will be focused on patient-facing staff. The next two, healthcare coverage and pathways for nursing, are also investments in our staff that we feel are critical to maintaining a high level of quality here at Mount Ascutney. I've included the loss from HHR on this slide. We are not increasing NPR to cover this cost, but the 3.5% NPR increase will generate enough of an operating margin for Mount A to offset the HHR loss. The consolidated operating margin between the two will end up being 0.1%. We just wanted to hit break even or thereabouts. As Dr. Foster noted, HHR has historically covered their costs, and even though we are taking steps to get back to that level, we are going to have to cover them this year. We'll discuss more about the steps in a little further on. Another area noted is weekend expansion of our walk-in clinic. We have additional net revenue budgeted for that. Our goal with this expansion is to provide a lower cost alternative to our community, saving them a trip to the emergency room or a half-an-hour drive to an urgent care provider. This is an extension of our primary care practice, and it is already well utilized by our patients. Next slide. There's been a lot of discussion around days cash on hand, and Mount Ascutney does currently have a strong balance sheet. We have for a while. Part of that, though, does come from our postponing building projects and building maintenance during COVID. We are now in the process of catching up, and we've got a lot of big projects coming up going on. You can see the list here. This $3.5 million worth of projects listed equates to an 18 days cash on hand. We anticipate needing another 9 to 10 days cash for coverage of HHR capital. And currently we are covering their payroll expenses while we stabilize. We expect that to continue for a little longer. We are anticipating our days cash to be reduced to 186 by the end of fiscal 2026. I'll now move on to the details of our budget, starting with patient revenue. Sisters, this shows our payer mix over time. We're seeing a shift to Medicare and Medicaid from commercial compared to our 2025 budget. We based our 2026 budget on the mix as of March, but we've seen a further degradation over the past few months. Case mix is a new metric this year. As a critical access hospital, we're not paid by any payer based on case mix. Looking at these numbers, we are seeing an increase, which is caused by our current shift from swing to acute. We've been working closely with the Dartmouth Care Coordination team to alleviate some of the crowding at Dartmouth, and we're particularly excited about being able to bring members of our community closer to home for their recovery. And we see this only improving as we get Epic up and running. Next slide. Here's some hospital volume comparisons. You'll see our budget change from swing to acute for patient days. Rehab's pretty flat. We're also seeing an increase over budget in the ER this year, and we do expect that trend to continue. Our transition to Epic will take place on October 4th. At the same time, Dartmouth providers will start working in our ER, And we anticipate there will be some continuity of care benefits, which should improve our throughput. So for OR volumes, our current surgeon is standing in as our interim CMO. We have budgeted for a permanent CMO, which would allow Dr. White to go back to full-time surgery. Next slide. So moving on to clinic volumes, we base these projections on actual staffing patterns by provider. You'll see some swings in here from our 2025 budget to the 25 projection back up to the 26 budget. We've had some vacancies in several areas. Many have been filled or will be by the time 2026 starts. This isn't an aspirational budget in the sense that we have a bunch of new providers that we haven't hired. It's all based on no. Other changes include adding a psychiatrist and contracting with Dartmouth for a women's health provider 1 day a week as part of our primary care practice. One of our long-term ophthalmologists is retiring this year, and we brought in a urologist in 2024 who has been establishing their practice. Usually takes a little while to get a new provider up to speed. So that's where all these numbers are based on. Last year, our budget order allowed a 2.2% charge master increase. Based on the 2025 budget order language, we are requesting a 3% increase. No charge in our charge master will be increased by more than 3% or will result in more than a 3% increase to any commercial care. Slide. Bad debt and free care are budgeted consistent with prior year budgets. We aligned our free care policy with Act 119, and we had anticipated more free care. That hasn't been the case for 2025, but we are hopeful for 2026. We do intend to work with undue medical debt once we get past our Epic transition. We just have a lot on our plate right now, but we'll be reaching out shortly. So pharmacy pricing impacts from Act 55 are not built into the submitted budget. It kind of happened all about the time that we were pulling everything together, and we're still analyzing, in all honesty. We've done some preliminary analysis, come up with a 1.9 million reduction at worst case. Could be, well, I say worst case. I don't know if that's worst case. We still have questions about how this is supposed to be operationalized, as I've listed a few below here. So we just would like to get some further clarity before we say, yes, we think this is what the final impact is going to be. So we appreciate it if we can get that at some point. So other revenue. 340B contract pharmacy, we have not been meeting our budget this year. We're monitoring what Act 55 will do to protect 340B here in Vermont. We have received notices from several manufacturers. Many of them are limiting it to the pharmacies located in Vermont. Our only contract pharmacy in Vermont is the Windsor Rite Aid, and unfortunately, they are in the process of closing due to bankruptcy. Hopefully, it'll be purchased by another chain that we can contract with. This has historically been our top contract pharmacy, and it has struggled this year with the issues that Rite Aid was facing. We have additional revenue from release of provider relief funds. These date back to the pandemic. It was determined at the end of our 9/30/24 audit that we could start releasing these funds over a 3-year period. 2026 will be the last year. And then the other items are consistent with prior year budgets. Next slide. We'll now move on to expense growth. Looking at the Oliver Wyman report, one of the main initiatives they recommended was for Mount Ascutney to further integrate with Dartmouth and to go on Epic. That will be happening this October. Very excited about it. We transitioned to Dartmouth's ERP system, PeopleSoft, this past January. Dartmouth is in the process of changing their fiscal year end to September 30th in order to better align with their Vermont affiliates. And once that's settled, we'll be able to utilize their StrataJazz financial analysis and expense management platform with our entire management team. Very excited about that product. I've only seen bits and pieces, but it looks like it'll be a great job. We are now sharing administrative
Where
staff
are
with
they?
Valley. So, excuse me, does someone have a question?
Sounds like someone's not muted.
We're now sharing administrative staff with Valley, in particular, Dr. Foster and I. Our permanent CFO starts in November, and that position will be shared. And this is all being done with the intent of reducing administrative costs as much as possible. Over the next year, we'll continue to review our operations and look for cost savings. Valley is fast tracked to go with PeopleSoft this January and then Epic in October of 2026. And once that happens, once that common finance and medical record platform is up and running, we will continue to explore sharing of staff and services. We do think we have a lot of opportunities, so we're excited about that. In addition, we're working with AHS and the Rural Health Redesign Center as they continue to the work started with the Oliver Wyman report. So another area we're working on is stabilization of HHR. We've contracted with Sonus Healthcare as of April this past year to get us where we need to be. This is their wheelhouse. This is what they do, is assisted living. Much of the volatility, especially around travelers in HHR, occurred when we had some kind of rapid transitions in HHR leadership. Sonus has brought in an executive director who's already made a difference. She's hired 6 staff as of this month to replace travelers. We had 12. And she's working on bringing in some private pay residents and also looking at donations. She's brought in a few already, working with the Dartmouth team. So we're encouraged. We seem to be moving in the right direction, but as you know, these things sometimes take a little bit of time. Take longer to dig yourself out of a hole than it did to dig the hole in the first place. So looking at our expenses, this is our largest expense category. I pulled together some summaries of salary-related expenses by major categories. You'll see over the past few years the impact travelers have had on our cost per FTE. And you can also see in 2025 and continuing into 2026, the investments we're making in our employed RNs. Done a similar summary of physician costs, which includes contract, and then all other staff. Slide. Physician costs are relatively stable depending on the mix of specialists. For all other staff, our budget is in line with 2024 actual. Next is benefits per FTE. This is a major portion of an employee's compensation package. This past January, we joined the Dartmouth Health Benefit Platform, which was a very positive change for many of our employees. We still have some work to do to fully align in our retirement plan, but we need to find some other cost savings before we can make that happen. Pharmacy cost is our other large expense. This graph compares our revenue and cost per thousand to the profit margin generated by just sale of pharmaceuticals. The costs have been split by drugs only, and then costs for drugs sold to patients per our Medicare cost report. We've included the estimated impact furthest over to the right if we lose 1.9 million of net revenue from Act 155. The true cost is more than just purchase price. There is a significant cost to process, store, and comply with many regulations that are in place to keep both staff and patients safe. And then as part of our analysis, we looked at payer mix. The majority of our patients who receive outpatient drugs here at Mount Ascutney are Medicare and Medicare Advantage. We then looked at our top drugs given to patients with commercial insurance and compared the ASP price per unit to our GPO price per unit, plus the allocated pharmacy costs. So this is just a sampling of some of the top ones. Lastly, we've listed out our 2026 capital budget by major category. The IT integration is the cost of just the clinical portion. ERP is considered complete in 2025. As noted in our CON, Dartmouth will be covering 75% of the cost as a transfer of net assets to Mount Ascutney. And thank you for the opportunity to present our budget. I'll turn it over now to any questions.
Thank you very much, Ms. Pitts. We'll start with Board Member Walsh.
Thank you. Thank you for the excellent presentation. It's a pleasure to hear from you all. I'm reviewing my notes for a second. You've addressed some of the questions I'd prepared in advance. I appreciated the challenges that you mentioned regarding hitting your budget. And I also appreciated the challenges that you identified in your community-minded opening, the community needs assessment. You've proposed 3 exclusions to meet the 3% OPEX benchmark. Did your leadership team consider delaying any of these investments or staging them over time, or using any of the reserves that you've gathered in order to keep the rise in those operating expenses a bit lower?
I can answer that. Yeah. Regarding health insurance, because we are on Dartmouth's benefit platform, we can't really, don't really have a choice with that. It will go up in January. The depreciation is a function of the asset being placed in use, which will be in October or so. That's a non-cash expense at this point, and the bulk of the outlay, the actual cash outlay for that, will be covered by Dartmouth. We are recognizing 100% of the depreciation on our books, and then the HHR costs, that actually gets covered as a pass-through through other operating revenue. So it's have it down in the expense line is just, it kind of skews the additional expense. So it's a little bit messy. I get where you're coming from. If we could, we would look at delaying. Yeah.
Yeah, I think it's an excellent question. It is something to answer, because it is something we thought about and discussed. We're trying to think through ways so we can do that without having to tap into cash reserves, for just the very reason why you have cash reserves, is particularly in thinking about budget in the February, March, April timeframe, with considerable uncertainty at the federal level, uncertain what's going to happen at the state level. You know, it's something that we continually revisit. But I think, you know, at this point, we thought, you know, we need to be pretty conservative and think through what we're doing in terms of our cash reserves.
Yeah, that makes sense. Yeah, I'm not trying to be nitpicky with the questions. We're just trying to also balance the affordability things and the healthcare.
I don't think it's nitpicky at all. I really appreciate it. I think it's, as I said in my opening, I think it's important to be collaborative and to understand that we all have the same shared interest. This is hard. This is really hard. And it's hard for you all, it's hard for us. And I think knowing that is I have the shared commitment. So I know we'll come together.
Yeah. You mentioned the HHR. Help me understand, do you have a long-term plan to help stabilize that? Do you expect future losses that you'll need to cover? How do you see this playing out over time?
I think, you know, our plan is to get back to break even. We have, this year is an investment year, and investment not only in a management firm that has a proven track record of being able to manage this, and willingly said, we understand this is an underserved population of mostly Medicaid patients that deserves high quality assisted living. Having hired an outstanding executive director, and just this month hiring an outstanding nurse manager, as well as reducing the number of travelers, which is the major expense, really allows us to get us back to break even. And then we can make the decisions of, okay, we know there's going to be a significant capital improvement. We're at a point where we think this is a long-term sustainable path. As an aside, I came from a health system that made the very difficult decision to sell 4 assisted living facilities, unfortunately, just before the pandemic. And so what happened, that it was a huge challenge for the hospital system, for patients who needed a place to go, and be thinking about the challenges of access to care during a pandemic. I've seen the downsides of making rash decisions to close necessary parts of the community just because it made sense from a financial standpoint for the 4 walls of the hospital. If you think about from a community standpoint, I think it's incredibly important that we everything we can to make this a sustainable option. By that, I mean break even.
Mhm. Yep. Well, I appreciate what you described going through with that. I thank you for sharing the story. It's I want to take another look at the community needs assessment. And when I see rising operating expenses in in an affordability crisis, one of the things that I'm looking for are, do the rising operating expenses, are they directed toward the community need? And you identified things like transportation and care navigation, food insecurity. But then the operating expenses, the increases were health insurance costs, other aspects. Can you talk through how you reflected on that, if you did, and how you'll prioritize those community needs with future operating expenses?
Well, I can speak, you know, as we think, I'll just speak a little bit about the health insurance piece. You know, it's an expense to the hospital, but it's a huge benefit for our staff. So 72% of our employees are Vermonters. You know, the hospital covers 55% of their premium. It's a self-insured plan through Dartmouth Health. So, you know, when you think about our population right here, we're providing that service to our employees. It's not necessarily a direct tie into the community health needs assessment per se, but having a stable workforce that doesn't have to worry about how they're going to pay for their own health care, I think can trickle down to those around us. You know, we have a lot of things built into our budget that we haven't necessarily called out. We have community health team people. We have a lot of staff meetings. We subsidize the Windsor Resource Center. All these other things that have been in our budget for a long time. So we haven't necessarily called them out as ads. They're just things we want to keep doing.
And to that, I think this is a long-term investment, in my opinion. And Celeste mentioned the Windsor Resource Center. I think also we manage volunteer in action. These are incredible resources for the community. It's our commitment, not just mine, but the team and everybody here at Ascutney, commitment to this community. What that means is investing in those community health navigators, those resources, the folks that are in the clinic that are seeing patients. Think about the Dolce program in pediatrics that is an incredible resource for all families that are new parents with young children that may be struggling or may just need some support. I think about what we're doing at Ascutney and what we're doing in that community too, and also the Blueprint program and where some of the donors that we're funding. And I think part of this is not only just what we're doing, but also making sure that people who want to support our community have opportunities to do that. One of the big resources we have, community resources, is funded by donors. And so part of our work is to go out and make sure that in a narrow operating margin, that we have people who want to submit and contribute to our community, give them those opportunities to do that. I think it's an investment. And what I mean by that is I think we need to think through the investment will pay dividends. If we have a healthier community that has resources, it means they don't have to come to our emergency department. It means they don't delay care. It means they are able to have access to those needs that keep them out of the hospital. That means we have to invest in those community networks. It means we need probably a director or managers of community health to help coordinate a lot of the work. That's what we've talked about with community resources and members of the team and volunteers in action, Windsor Community Resources, others. I think we're just starting that work. I think that is reflected in our budget. It may not necessarily get called out in this presentation, but it's incredibly important to me, both personally as well as being the CEO of this hospital. It's important to the physicians, the senior team, everybody here is that we're serving.
Thank you for those responses. They were excellent. I think it's worth calling them out in future years when you come. It really helps us see better the connections between operating expenses and community needs and the alignment of your facilities with serving that community. I really appreciated the answer, the part of the answer speaking to the benefits to the employees. I don't have the data right in front of me, but I imagine that your organization is probably one of the bigger employees or employers in the region. And so that is taking care of the community. when you look at it that way. So I appreciate those answers. I wonder, could you describe for me what types of discussions did you have about internal cost containment efforts, and what did you explore, what did you reject when you were trying to think about this growth in operating expenses? How did you reflect on what do we need to do versus can we better control, manage things internally so that we don't pass these costs on to our patients?
Well, our first start is, as I mentioned before, we are up to our eyeballs in the Epic conversion and integration with Dartmouth. And, yes, we've been having various discussions about, okay, look, we need to start looking at our service lines. Like I said, we're working with the Rural Healthcare Design Center and all that. But our biggest focus right now has been getting over that finish line with Epic. It's been a huge lift. Getting onto the ERP was also a huge lift. So we've managed to make that happen. And we're just going to get that work done and then hunker down and see what it does. It will generate some savings. We just need to get over the finish line.
I think too, when it comes to thinking about expense reduction, we think about that is what we do for quality reporting and data, and having access to the system quality reporting data in the same way that we're not on the same EMR. So a lot of it's manual, which means more time, more manual pulls to get that quality data. When it can be automated, that's an automated cost savings, on top of which you have more line of sight on the areas that you can affect to increase quality. I think that's a really important nuance that could be lost in thinking through some of the advantages of that. The fact that Dartmouth Health is paying for most of that obviously is helpful. I think to your question too, what have we done on the administrative side or the non-patient facing side to think through how can we reduce expenses? I think it's important to recognize that, when we think about, the costs don't necessarily translate and do not translate into higher margins. In fact, it's actually the exact opposite. And I think as our budget reflects, we're actually not asking for a significant increase in just a 3% increase in our charge master. So a lot of those expenses we are absorbing without passing it on to patients. I think the last thing we want to do when the launchers are already facing double-digit premium increases is compound that problem by raising our prices even when we're facing increased expenses.
Yeah, I appreciate both those answers. Again, they're thoughtful. I think one of the things when I see a budget with rising operating expenses but stable revenue and thin margins, I get concerned. Yes, we're concerned very much about the affordability crisis, but then I start to get concerned about sustainability, right? And so just seeing where, as we keep meeting over time, just thinking about demonstrating for us that what you considered, what you rejected regarding operating expenses and managing those internally, that'd be very helpful to us. And I do believe there's a lot of promise with system integration and things like Epic. But I'm sure you're also aware that we often see across the country and then here in Vermont that that conversion is very costly and the anticipated savings don't always materialize. And so helping us track the savings that result, the return on investment from that integration would go a long way toward helping us review your budget and seeing how it fits with the statewide efforts that we're making.
I agree with that. I think that's important, having gone through that in past organizations. There can be a lot of hope and promise, and that lets us see what that looks like on ROI. And it's important. It's for you all to be informed, but also for us as we make decisions about did what we thought would happen actually happen, and if it didn't, how do we pivot? Because sustainability is a key tenet to what we do, and we will be here for long term. How do we make sure that happens? And particularly going to next year when we already know there's some anticipated challenges, both with Act 55, but also the lack of the provider relief funds. Those are off the top challenges that we're going to face.
Yeah, no, I think I thank you for that. I think it's you started off with a partnership and really working together, and I think If I'm trying to share with you what I need to look at to keep the oversight, this idea about the statewide system, and a lot of it you may already be doing, but how can I help you share that with me in a way that we can put together? So
That'd be great.
I appreciate that. Just a second. Just a couple more things. Your administrative costs in the documents that you've shared, they have risen. And so I'm just wondering, do you do any type of internal benchmarking against peers, or how do you try to level set for yourselves where you feel you ought to be on non-direct patient care expenses?
Well, fortunately, part of the budget process is the sharing of data, and we were able to look at the clinical to admin staff ratios of our peers across state, and we landed pretty squarely in the middle. So as a small critical access hospital, I feel pretty good about that.
And we will continue, that is one of the things that as we look at our costs and how do we reduce, and I think this is pretty true for any hospital I've worked at before. Really, if you're going to reduce costs, you don't want to do it with the costs that are going to impact the patients. You want to do it for non-patient facing, and that will be our focus as we move forward. With integrating with Dartmouth, I think a lot of the administrative type of burden hopefully will be reduced from us. I mean, to your point that we have to monitor that, 100% agree, and
Yep.
But then I would also say in some cases, and I don't know if this will end up happening, but what I've seen in the past at other places is sometimes it's not necessarily that you're reducing costs, but you're avoiding extra. So just something to kind of keep in mind.
Yeah.
As regulatory needs require all the things for quality reporting, things like that, with the ACO being gone, we could fall under the burden of not being able to report out on MIPS, because we'll be on Epic. Dartmouth will be able to do that for us. That would be a hit on Ascutney if all of a sudden getting hit with that penalty from our providers. So that's not necessarily related to costs, but if we had to hire somebody to do that reporting for us, there would be.
I
And
understand.
sort of make an editorial comment. I struggle sometimes with sort of understanding patient versus non-patient facing, because as a
Right.
physician, we choose to work in healthcare. All of us, whether it be in finance or whether it be on the front lines, or in healthcare, we are caregivers in the same way that someone else would providing care. And so I think, the ideal is to get to the sweet spot where everybody is a necessary cog in the wheel to make sure that patients are there. The question is, are they being paid appropriately, which I think is really the important point, particularly when they're not generating their own revenue, aka income. And so, part of that is also benchmarking with peers in the Dartmouth health system to make sure that we're competitive, but also understanding the challenges of Vermont. I think too, when it comes to administrative costs, the CMO that we're hiring is a half-time position, half-time clinical. It's deliberate because we think, we can do that. We need to have someone who is also still actively practicing medicine, but it's a way to say we're not going to have a full-time administrator position and that high cost. That's a very deliberate approach to that. And it also means that we can offset some of the costs that we're now paying for medical directorships in order to change that to make sure that we're getting the value that we need out of those physician leaders, so that they're doing and working at the top of their lives and doing what they need to do, as opposed to what's had to be done through this transition of interim leadership.
Yep, that makes sense. And I too have been other places, worked with other senior leaders on different organizations, and I've asked a couple questions in a row about admin expenses and growth and system integration, because it's so common to see the promise of system integration leading to savings, but then those savings not materializing. And so I'll be looking for that in future budget submissions for you, and just want to share that. And one final question about with system integration. I wonder if you could describe for us how your leadership, your board, what processes or what type of thinking goes on when you are part of a larger system that's in a different state. That system may have requests of you or expectations that are not directly aligned with your local community. And how, if that were to happen, how do you anticipate trying to deal with that?
Well, so it's a great question. It's something I actually asked, it was a year ago today that I would interview for this job, and I actually asked that question.
Yeah.
Because I was thinking about that is, we're on the other side of the Connecticut River, and a very different state, and yet we're part of that same system. It's important to maintain autonomy, but also understanding that what works in New Hampshire may not work. And understanding that, and we've had that conversation, and I've found the system to be incredibly supportive, understanding the unique challenges of Vermont, and to be able to say that one size does not fit all, and that we need to understand what's going to work for Mount Ascutney. I actually had that conversation this morning with some of the strategic leaders to think through what is it that we need to do specifically for Mount Ascutney and Vermont that may be different. It may be a different framework. It may not fit into what works in New Hampshire or the health system. I found everybody so far in the 8 months I've been here to be very receptive to thinking through that, understanding that, and you have to reminder, for instance, on some of the transitions to Epic and thinking through that, or thinking through some of the transitions to other employees. We're in Vermont. It's not New Hampshire. We have to think through, not in a bad way, but just as a way to frame it, to say, we need to think through what the challenges are for Vermonters and what is in the best interest of Vermont. That may be different than some of the affiliations that you've had with other hospital systems. I found it to be collaborative, supportive, really focused on for the right reasons, that is patient focused and committed to serving Vermont, serving Windsor, serving this community of the Upper Valley in a way that fits Ascutney, not just being absorbed into the green circle of
Right. No, I understand, and I think we've had there have been longer relationships between Dartmouth and Vermont facilities, and I think in general has been very good. And your experience over the last 8 months has been very good, and they were able to answer your questions in a way that you felt comfortable coming into. The reason that I bring it up is from seeing other systems where it didn't always go as well, and just thinking, if you haven't, just kind of creating some scenarios to think about how you as senior leaders would inform your board, and how the board and you may think through any of those differences. Not because you definitely anticipate them, but if they come as a surprise, it's a lot harder than if you've thought about it ahead of time. Thank you for your thoughtful responses, your thoughtful submission. It's been a pleasure talking with you, and that's all the questions that I have.
Thank you.
Dr. Merman?
Great, thanks. Hello all, thanks for the presentation. I have a few questions from the presentation, a few that I have prepared and a few that are related to things that Tom asked about. Maybe real quick on the presentation, on slide 25, you have a payer mix slide. And I was just wondering if you could tell me how you calculate that payer mix. Is that gross patient revenue, net patient revenue, individuals?
Gross patient revenue.
Gross patient revenue. Okay. Thank you. And that was all that I think I need to touch on from your slides. So looking at the rate decompensation sheet, you don't have to pull it up if you don't want, but Medicaid is, my understanding is Medicaid switching to a global payment in Vermont in January. And it looked to me on the rate decomp sheet that the payments to Mount Ascutney were about $3 million, just under $3 million in 2024, projected for 6.3 in 25. And then I think you come in at just under that. What are your assumptions about how that Medicaid global payment is going to be designed for Mount Ascutney, and how did you end up at the 5.9, I believe it is, that you put in there?
Well, I'll let Andrew elaborate if I say anything wrong, because he's our rate decom expert here. Just look at it and say, okay. But our thought was that our understanding that it's not mandatory to do the global budgeting right out of the gate. So we were going to see how it settled out before we jumped on. So what we did was we just assumed that the monies from the ACO, which in the past had been considered other operating, correct me if I'm wrong here, would slide up and then just become part of the fee for service payment. So
Okay, so you'll be a
that's
fee
where-
for service.
Yeah, it's really a shifting of, yeah.
Okay.
Yeah, we expect it to stay pretty flat.
Okay.
We didn't expect any increases or anything.
And
And it's based on current experience.
And it's based on.
January,
Right.
October through March.
okay, I was curious, looking through some of the ahead modeling for
Yeah.
how one would determine a Medicare global budget. It's based on, either prior year, but their model bases on a blending of a few years. So I was curious if there was a way, but you're just going to stay in fee for service, so that makes that
That's
less
our
complicated.
thought at this point in time, yeah.
Okay. On page 36 in my book, which is response to some questions, there's a table that has Medicare, Medicare Advantage, Medicaid, and then this is regarding the NPR for outpatient drugs only. And I was surprised to see that for when the payments dropped to 120% of ASP, the Medicare Advantage payments dropped substantially. So Medicare Advantage FY25 annualized was 573,000, but only 74,000 at that 120% ASP. So it decreased by about 500,000. So are you getting payments from Medicare Advantage that are like commercial range payments?
Yeah. So the way Medicare Advantage works is they pay us usually some sort of, sort of a variation on Medicare cost, but it's always a year behind. So we'll get our rate letter from Medicare in, I don't know, May from the previous year. And at that point, we'll notify the carriers. They'll increase or decrease their rate. So what we anticipate happening is that we will decrease the costs in January. Decrease our charge master in January. The Medicare Advantage plans will still be paying us a % of charge based on the prior year cost report. It will be based on the 2024 cost report at that point. They will then pay us. We won't really get a settlement from them, and there will be no settlement. There'll be a rate change in May of 2026 before it all settles out. So we'll have a good year, closer to a year and a half before they'll catch up. Now, we may be able to do an interim cost report and see if we can get something changed there. We'll have to kind of work through that, but we would need to be halfway through 2026, I believe, probably even further along before it would happen. So it's going to be a bit of a dance. Yes, we will be impacted. It will eventually catch up, but it's going to take a year and a half, and we'll lose that year and a half in reimbursement. It won't be that it will settle up and they'll just pay us what the difference is. I don't know if that made really clear sense. We can kind of line it all up a little differently and get back to you if it didn't.
That may be helpful. I haven't seen
Yeah.
such a dramatic reduction in reimbursement from Medicare Advantage due to the implementation of that Act 55.
Right.
So
It's a percentage of charge payment. And
Right.
if charges decrease.
Yep. Yep.
PSR will decrease.
Right.
Okay.
Yeah. So they pay us % of charge based on our overall Medicare cost report. And then if one of the charges drops significantly, they'll still pay their % of charge. So let's say it's 55%. So if now all of a sudden we go from charging, I'm just going to use a random number, $1 million for something, and now all of a sudden we go down to, 100,000, they'll pay the 55% on the 100,000, not the million like they were.
It's 37%.
Oh, it's 37%. So our cost to charge, our overall cost to charge is 37%. So all those reduced charges, because we can't set up our charge master to charge differently for different payers. Well, that's not right anyway. We just always charge the same for everyone. So that reduction to the 120% of ASP will go out to all payers, Medicare, Medicare Advantage, Medicaid, out-of-state payers. And because of the way our contracts are set up with the Medicare Advantage plans, and because of the way their structure works, they'll continue to pay their 37%. Their 37% on whatever we charge.
Okay.
So did I
It does.
explain that?
Yeah, no,
properly?
I think I get that now.
It's complicated. I know it's a strange system. Yeah. So they pay
Okay.
cost, but not right away.
In the submission, there was discussion about totally different topic. Sorry for a curveball at you. Executive compensation, variable compensation, that it was related to the financial performance metrics of Mount Ascutney and Dartmouth Health. Could you provide those financial performance metrics to the board?
Yeah, we
It
can
could be
certainly do that.
it could be confidential if you feel like it needs to be. That's fine. I'm
Yeah,
not
no,
sure what the rules are on that.
Great.
Yeah, we happy to do that. I think
Yeah.
that is sort of the gateway tiers of what we do for the variable part of compensation. And it unlocks it. If you don't hit those targets, it's locked.
Right.
Okay.
But it is
Right.
more than just financial performance. There are other components. So we'll
Okay.
send that.
Thank you. There was discussion, Tom discussed return on investment of Epic. I just want to sort of say that from the Vermonters' standpoint, from the Green Mountain Care Board standpoint, that R of return is a reduction in expense, not necessarily an increase in commercial revenue. So we want to make sure that the return doesn't end up being that Vermonters pay more through enhanced billing. And you discussed this, I believe, in your presentation, that you expect the case mix index to go up with the implementation of Epic. So my question for you is, are you expecting enhanced revenue capture once Epic is up and running? Are you expecting to generate more revenue through the implementation of Epic? And would this be across all payers?
Yeah, it is possible. I think, though, that would come at the expense of Dartmouth, to tell you the truth. It would be a shifting up. It wouldn't be that there would be brand new patients out there, but it might be that a patient who is sitting at Dartmouth slides over to Mount Ascutney instead. So it wouldn't necessarily be additional cost to a Vermonter. It would be just a different location.
I don't think that, Epic oftentimes is sort of in EMRs in general as a position are more sort of in the enhanced billing and coding rather than actually being something that can document for the true patient medical record, as maybe I'm old school, but I remember actually handwriting notes. But that sense of what it is, and sort of to your point about whether we're going to see enhanced revenue capture as a consequence of more efficient EMR, I think as a critical access hospital and a really tight finance team, we're looking at every nickel and every penny as it is. So I don't anticipate there to be more efficiencies gained by being on a new EMR in terms of more billing or more revenue capture. If anything, I think what we could see, to your point about return, is really to think through what those efficiencies are, reporting for quality, for safety, or getting a sense of where we are compared to benchmarking to our peers, and seamless integration of medical records. And so reducing those expenses of, that time when it comes to getting records and getting care and the challenges you have on handoffs or cross coverage or MedRec that come from different EMRs.
Just a quick numerical question. So guidance for operating expense growth is 3%. You guys are coming at 5.2%. What's the dollar amount of that difference?
Had that somewhere.
1.6 million, 1.7 million.
1.7. All right, that was in there. Okay, now I understand. That's where that was. Okay, 1.7 million. Okay. So the 671,000 of additional depreciation for the Epic system, is that in addition to the prior annual depreciation of your legacy EHR system?
That is probably fully depreciated at this point. Cerner, I think, we're not depreciating any longer. mean,
Okay.
Epic will be over a 10-year period that we're depreciating, but probably Cerner was 5 years. We've
Okay.
had it 12.
And we're getting the, cost report settlement benefits from recognizing the entire expense. So it's a really win-win for the state and for Ascutney.
Okay. Another expense question. It appears that you're switching from the contracted APP model for your emergency department to now a contracted physician model for the ED. And I was looking through the physician expense increase. It looked like it went from about 8.2 to $9.2 million this year. Is that difference, that $1 million? Is that the switching from the APPs to physicians for the ED?
Certainly a big part of it.
That's, part of it. Yeah.
Okay. I was trying to figure out where that was coming from. So there was also a discussion how you expected to see more Medicaid patients in the emergency department because of switching to a physician model. Can you explain why you would expect a higher Medicaid?
Did I
It was
say
in the
Medi-
it was in the response to board questions somewhere in there.
Oh,
Or-
yeah,
Medicaid being the highest utilizers of the ED.
Medicaid or Medicare?
Medicaid typically is a very high user of the ED.
So it's to increase.
I think we were just looking at our payer mix within the ED itself, what our traditional payer mix is.
And I think too, that might be worth getting a little more information, I think, as we think through one of the tactics that we alluded to, of expanding walk-in care, walk-in hours, particularly for those lower acuity patients. Oftentimes ED is higher volume because it's an access issue. I share your concerns, particularly when it comes to the higher cost physicians, as opposed to APPs. I think we've been well served with an APP group that has announced that they're going to close at the end of this year. And so thinking through what we're going to do in terms of servicing our community, but also being able to ensure that we have physicians in-house that can respond to emergencies for patients and also the rehab unit. I think this allows us to have more cross coverage for those physicians.
Okay, so the APP group is closing. That was what prompted
I don't
switching
know if
to the
that's,
physician
I do
group?
not think, I don't want to be clear. I don't know if those are causal. I do know that they're closing. Yeah.
Yeah. So regarding the ED, I was just trying to figure out also how to reconcile those increased walk-in hours with the assumption of reducing ED visits, but then sort of the idea that the ED visits are going up and now you're going to be having a higher expense base and a higher revenue base because of switching to physician.
Yeah, I really
model,
don't want to be in the position where we have to increase the number of emergency visits because it's a revenue generating model. That is not my approach to care, nor is it good for this community, or does it decrease costs. I think it's necessary to have high quality emergency services for this community to be here when you need it, but it cannot be what we count on to drive revenue. I think this is an example of us being able to share a part of the system. So these are Dartmouth Health emergency physicians that will be able to do shifts here as well as be connected to Dartmouth Health. And so in some ways, although it can look like part of that expense is related to physician expenses, I think it leverages the systemness and gains more efficiencies that way.
Okay. It's just it looks like about in the 1.7 million, it looks like $1 million cost driver. So just trying to understand that. Okay.
I don't think it's a target emergency. We're adding a psychiatrist, a full-time psychiatrist that is starting soon. That's an expense driver, which we're going to bear 80% of that cost and share with Dr. As well as some of the physician drivers that we're thinking about when I'm out in locums, as well as physiatry, both inpatient and outpatient for connected with our rehab and urology services, which we think there's an opportunity there to reduce some of those expenses. All of those are considered are likely to go up next year as well.
Okay. I have on page 3 of your submission a reference to shifting cost to DH for shared services. I'm trying to understand how there's a place in the budget submission where I can understand the financial impact of shifting to DH for these shared services, and where is it? I'm trying to figure out where in your budget submission it shows the money that's being paid to DH, either through shared services or any other transfers to DH.
Shows up in other purchase service, right? Is that where that shows up in adaptive?
Previously, yes, and we've carved it out to under shared service.
Okay, there's a
adaptive, I believe. Yep.
All right.
So we had a changing accounting process with a change in PeopleSoft and trying to align better with Greenmount Care Board standards, data submission standards. But I
Okay,
can
so
say, IT is going down 500,000 actual to budget. For accounting, my department, accounting and finance, is going down substantially, 800,000 in next year's budget because of the shared service allocation.
And then how
So
much
we're
is the
seeing
shared service
shifting.
going up? And so that's going down in the non-shared service, and then how much is the shared service going up?
So shared service gets recalculated once a year. And during the transition periods, there's a lot of leniencies that are given to us. So we got some pretty substantial credits. Goodness, I think, was it four?
Yeah,
We went from a $1.2 million cost or $900,000 cost allocation in 24 to a $440,000 credit back in 25. We're going to go to a 1.1 or 1.2 in 2026. And so I guess as we keep onboarding and finalizing our integration, those will stabilize. But long-term savings, and we don't get the math until next June. But I'm thinking it should be around $400,000 a year for accounting and finance, and around $400,000 or $500,000 a year for IT. Just those two years along.
Great. I just have one final question for you. So in the past regarding OneCare, my sort of impression of the conversations from Ascutney was you're paying more into OneCare than OneCare is paying back to you, and it was not a particularly beneficial relationship. This budget submission sort of puts in a lot of questions about what's going to happen when OneCare leaves. This has been a beneficial thing. So I guess I'm just trying to understand, has OneCare a net been a benefit for Mount Ascutney, or has it been a cost for Mount Ascutney, or is it more complicated than a simple binary relationship?
Well, I'll give you that. It's more complicated, but we spent over $2 million in dues in the past 7 years, and I don't think we've recouped that.
Okay, thanks. All right, well, thank you so much. That's all I have for you for now.
thank you.
I think I might be up next. And so thank you for the presentation and welcome to your first Green Mountain Care Board hearing. So a couple questions. Actually, I have a fair number of questions, but hopefully they're fast. We can get through. You mentioned, I want to talk a little bit about HHR and the projected $475,000 loss for 2026. And the need for it to be covered by the operating margin at the hospital. So with 35,000 residents, that's over $13,000 a year in losses per resident. And it's, as you mentioned, it's Medicaid, predominantly Medicaid. In our hospital budget review, we are actually required to consider the extent to which costs incurred by a hospital are in connection with services provided to Medicaid beneficiaries being charged to non-Medicaid beneficiaries. So I have at least one question about this. It's a loss. You've got a plan. Have you reached out to DEVA for emergency relief or any kind of increased rate to cover those losses a different way other than through operating margin?
Excellent thought. No, we have not. We'll put it on our to-do list.
And we're in constant communication with DEVA, especially around assessing patient levels or resident levels, like ERC level 1, 2, or 3, trying to right size their assessments to right size payments. So
well, it would be
Yeah,
helpful
we can
to
certainly make
hear.
them aware.
Yes, it would be helpful to hear the result of that inquiry about emergency relief or increased rate. Also to know how the Medicaid per diem rate there compares to other Vermont facilities.
Okay.
You're also asking for relief from the GMCD expense growth target for the labor costs associated with that facility. Since it's a subsidiary, we don't really have line of sight to the performance and operational efficiencies of that organization. So to better justify the request for relief from that benchmark, it'd be really helpful to see the budget for for HHR, to see the performance and operational efficiency benchmarks for HHR. And also, as I said, to hear more about what other efforts have been made to try and close that gap so it's not coming from the operating margin of the hospital.
Yep.
So that's more of a follow-up. You're asking for relief from the expense growth target related to the health insurance for your employees, which I understand to be a Dartmouth-Hitchcock self-insured plan. So again, this is probably a follow-up question, but I'd like to understand a little bit more about the base cost and proposed rate growth and whether that's reasonable. And one way I thought would be helpful to start is to know how the Dartmouth's self-insured plan reimburses for inpatient, outpatient, and professional services compared to Medicare in the self-insured plan. What kind of discounts is Dartmouth-Hitchcock self-insured plan giving even on its own rates to its employees? Some helpful to understand the cost of that plan.
Yeah, we'll have to follow up and get back to you on that one.
I understand that. That's why some of these will be going quickly. Member Merman asked about your variable pay, and it is tied to employee engagement and financial performance. When you submit the follow-up information there, can you please describe how the variable pay for fiscal year 26 will align with the state health reform goals that are outlined in our statute 9371? Those goals involve cost containment, universal access, elimination of unnecessary expenditures, sustainable financing of healthcare. How specifically are the variable pay tied to those health reform goals? When you're
I think we will do our best. I would say that for FY26, that is something that the board sets as to what the variable pay, if there is any variable pay. And we can talk about that, whether that's the right way to do it or not. But that typically will not happen until we have an idea of what that would be. We may not really have an idea of what that would be until December, January timeframe before it gets approved for the board for FY26. Only because we want to make sure that we have it aligned with both the Dartmouth health system. But I think it's really important to me that we have meaningful metrics, that we have things that can be tracked, that can't be manipulated, that are data that is pulled objectively, and that it's something that is in some ways an aspirational target of where we want to be, not a gimme, not a participation trophy. Those are really important to me. And so I think that takes some thought and design, and I completely agree with you. I think it's important to align with the values of Vermont, with the health care policies of Vermont are, to make it something that you all feel comfortable with, if that's the way we're going to do, if we're going to have variable pay at all. And to me, that's something that is a broader conversation when it comes to executive compensation. And it's something that I'm happy to have more conversations with you about that, just to learn more about the philosophy of what I can do this new year. I think it's important to make sure that whatever we set is aligned. I would say too is that although we're part of Dartmouth, we do have some flexibility, particularly when it comes to CEO compensation, of what variable pay is included.
Okay, yeah, and I would definitely, I would have your HR team and your board look very, very carefully at the legislation that was just passed and what is required of executive compensation. On the high and low margins services spreadsheet, you report 0% for the commercial to Medicare ratio for every service line. Can you talk about that a bit more?
Yeah, we interpreted the request as, are you charging differently by payer? And we charge the same for every payer. That's how we interpreted the question.
So you were relating it to the charge master.
Yeah, gross charges, yeah.
So I think what we're looking for there is your average reimbursement, commercial reimbursement rate relative to Medicare by service area.
Okay.
More consistent with, for example, what's in the RAND report and what's in other data to try and understand on average reimbursements, how do they relate to what Medicare would pay for services for your commercial payers? So factoring in discount out charges, all of that. So we really want to understand that. So if you could fill that back out with that understanding of really looking at average commercial reimbursement rates, that would be really helpful.
When we do that, just for clarity, because I'm looking at the team here, and I want to make sure we get you the information you want. So if you feel like after that follow-up, you're still not getting that, please make sure that we are able to provide you with the information you need.
Great. I think we will, and I think our team will too. Yeah.
Can you tell me exactly where that was, or maybe the team can, oh, Andrew had it, never mind.
It's in the high and low margin services spreadsheet.
Okay.
Yeah.
Thank you.
Just with relates to ACO dues, it looked to me like you are booking ACO dues for fiscal year 26 in the cost inflation spreadsheet.
3 months worth. I think we had.
Oh, is
3
that what it
months
is?
worth.
Okay.
Yeah.
Thank you. That's helpful. Yeah.
Done as of the end of December.
Spread out. Okay. Thank you. That's helpful. And then my last few questions involve service line changes, and I want to make sure that we have all the information that we need on service line adjustments that are anticipated for 26. You talked about elimination of oncology and pain in your presentation for fiscal year 26. Is that all we should expect? Or
I want to be clear on that. Those were eliminated in 2024. And part of my understanding is that what changes in service lines, and that's deliberate. I do believe that words have meaning, and change as opposed to elimination is a key word, in my opinion. I think that those were basically loss of provider, not a deliberate change and not a deliberate elimination of those services. Those are the only two that we do not currently have and do not anticipate necessarily oncology, perhaps, but that's a broader conversation, largely influenced by the Act 55 conversation. But I think in terms of other service lines that we want to eliminate, we have no plans to eliminate service lines.
Okay, I think just to clarify, I think any elimination, whether it is because of a provider departure or an intentional reduction, any change of service line is something that we would want to understand and know, because it obviously impacts access to services.
Yeah, so I mean, I think the simple answer to that, we're happy to follow up, is that we lost a provider.
Okay, so it's both of those practice areas. And is there any other, for whatever reason, elimination of any service lines anticipated?
No.
Not at this point, no.
Okay. And is there any reduction in service lines anticipated? So reduction could be in the form of a reduction in beds or emergency room capacity or clinical capacity, anything that would be, say, 15% or more reduction in capacity. I'm making that number up, but
yeah, not that's anticipated. I think, we all feel, and I feel particularly strongly that what we do in a budget, what we do to services, is the last thing we do is reduce or eliminate services. So there are no plans to do that, and nothing I anticipate.
Okay. And then finally, you mentioned working with RHRC to improve sustainability. Can you share with us any potential opportunities that have been identified in your work with RHRC so far?
AHS has been working with them. I think we're waiting to hear from them. Our next step is what develops some smart goals.
Yeah, I mean, I think we're still kind of waiting to see what their final report is going to be. And happy to kind of share with that as we think through that collaboration of what we're doing. It does feel like there are a lot of people that are working on this, hopefully together and not in parallel. But I think what we're looking at again is some of the same things in Oliver Wyman and what we could implement that in terms of IT services, shared services, but also what should we be doing? And where are the opportunities for us to be a regional center of excellence? And that's one of the areas that our RHRC is really focused on is that regionalization of tier 1, tier 2, and tier 3 services. Where does Mount Ascutney fit in that? I don't think we've had I have not seen the final report on that yet. But I think, it goes back to our strategy of what are we going to do, and let's do it well. So is it rehab? Is it inpatient services? Is it ED? Is it primary care?
Okay. All right, great. Thank you so much.
Member Teachout, any questions?
Yes, I do have a few. Thank you. Nice to meet you all. I'm going to jump around a little bit. I wanted to start with the capital investments you had on slide 23. And I wanted to know first if they were prioritized. And then second, I wanted to ask you specifically about the ophthalmology investments. My question there is, why are you investing in a program that seems to have a pretty significant decline in services?
Oh, so, well, sort of a dual answer there. So ophthalmology, at the moment, what we're doing for the expansion is we're actually taking our space here on the Windsor campus, and we've taken over the space that formerly had been billing and what else? I forget what else. We're converting that into the, it's adjacent to the existing ophthalmology clinic. And so we're just taking that whole side of the downstairs of the building and turning it into exam rooms. It's largely for throughput purposes, but the reason for the decline is that we are losing a provider who's been with us for a very long time. Actually, Andrew found a old newspaper from, what was it, 1990?
Yeah, so Dr.
1990.
Dr.
Dr.
Connor's
Connor's
retiring in October.
Yes.
And so that's part of the law.
Yeah, that's.
We
the
also
reason.
anticipate one of the providers is going to be out on FMLA. She's having her first child, and so that is sort of in budget those reductions. There's a huge opportunity, and again, one of the things that we've seen in from this community is in Windsor is a lot of people have to travel out for basic eye care, and they have to go to a higher expensive place for care when they can do it here for either routine cataracts or non-operative services, including some injections that could be done here. And part of that is to say, you know, we have a pride in the ophthalmology services we're doing here. We're just in a position where we need to think through what are we going to recruit for, how are we going to do this, optometry versus ophthalmology, and also thinking through some realizing efficiencies of economies of scale by thinking through what we can do here at our health system to become a regional center for excellence in ophthalmology.
Thank you. My next question is around your Medicare Advantage assumptions, and you had some pretty large increases in your Medicare Advantage population. And I think you said in the narrative that you know, it was because of growth in that sector. Are you seeing a lot of them from New Hampshire? Can you give a little bit more explanation about that assumption?
Don't know as we necessarily know where their home base is, but we definitely have been seeing a increase in Medicare Advantage patients. We would have to get some further information on that. I think we probably can run a report that says where people that those plans live.
That's okay. And how does that increase impact your commercial revenue?
If people are leaving a Vermont Blue Cross or whatever plan and going on to a Medicare Advantage plan, it really is a shift. Whether they went on to a Medicare or a Medicare Advantage plan, it's still a shift. But as we noted before in Dr. Berman's comments about, well, wait a minute, how does the whole Medicare Advantage thing work and how do you get paid? It's a bit of a myth that Medicare Advantage pays the same as Medicare. It kind of does, but it kind of doesn't. Being a critical access hospital, cost reimbursed by Medicare. So if we're underpaid by Medicare throughout the year, it settles up on the cost report, but it never does with a Medicare Advantage plan. You get a bump in your payment the year after, but it never really does. So for a critical access hospital, we actually prefer the traditional Medicare because we know we'll get our costs pretty much covered. Not quite, but pretty much. So to see any shift from a commercial insurer to either Medicare or Medicare Advantage, it's a difference. So for us, we prefer traditional Medicare. So the trend in Medicare Advantage is a little disturbing, but I think it's across the country. I don't think it's just Vermont. A lot of advertising dollars are spent on those programs. It always makes me nervous.
I am aware. So then I wanted to jump to the pharmacy questions. And there was some in your narrative and other places about 340B and not getting as much revenue from your 340B pharmacy program. Do you know if New Hampshire has the same protections for the 340B contract pharmacies that Vermont just put into place?
They do not. They do not. No, they do not.
They don't, but some of the manufacturers have been extending the same protections across the country.
Right.
So I don't know.
Yeah.
I know DH has received, their 340B team has received some letters.
I do know that, as highlighted, the main contract pharmacy that we have is Rite Aid, and that's in Windsor, and so when it comes to Vermont contract pharmacy, currently, we don't have a really good option.
Okay. And then I wanted to, just because the reasons for your overage, one of them was the health insurance premium increases. Did you save money when you joined the Dartmouth Hitchcock Employee Health Insurance Program? Maybe a year ago? I'm not sure exactly when you merged
That was a
programs.
couple of years ago. I believe we did. I believe we did. It was, I don't think we benefited a lot in terms of cash savings, but in terms of member benefits was substantial.
And obviously that was before my time. I can tell you that Valley Regional in New Hampshire is going through that right now, and they have realized a cost savings. And I don't know the exact number, but it is significant. And I would imagine the same thing would be true for Ascutney. We're happy to get that information. Historical.
Thank you.
Were we self-insured before then?
We were.
So we were self-insured, Dartmouth is a self-insured plan. So it kind of spreads out your risk a little bit too. You, as you're aware, the bigger the pool, you're a little more protected. So, and Dartmouth has made some changes to how they spread out that risk too over the past year or two. So,
Do your
hopefully
employees
we can-
get a better price when they go to Dartmouth through your new plan?
yes.
And let me just jump to there's quite a bit around the 120% ASP cap. And I know others have asked, but you cited the loss of staff and a reduction in patients in your infusion clinic recently. And I was wondering if that lessened the impact of H266 for
Yes, it
your
did.
organization.
Yes.
Yeah, it definitely did. And it becomes harder to project what it will be in the future too. I think that becomes more of a strategic question of what we're going to do. And the cloud of uncertainty makes any logical decision on ROI really, really difficult. Because if we lose a provider that's going to be of infusion and we're not sure what the reimbursement is, and we look at what happened before we did have a more full, robust oncology function and a provider, and we're looking to invest in that again, and we're now pegged to 120% ASP, that becomes a real difficult financial math. And so those are the questions that we're.
Could one of your options, or is one of the options you're considering moving those services to New Hampshire?
So we have increased the infusion at Valley Regional, and thinking through that, I would argue, having practiced and run a cancer center in a rural area, that having access to care close to home is incredibly. One of the reasons we keep the infusion center open is because patients need something as simple as a port flush. And if you've ever gone through that, if you have to go to a major academic center, park in a parking lot, take a day off from work just to get your port flush, that's a huge inconvenience. And so while it may be that we're losing money on that, it's access when you can park in the parking lot right out front, walk 10 yards in, get your port flush. That's a lot better for patients than it is to make them go travel even across state lines in 30 minutes or take several hours or a day off from work for something simple. I think that's really important in community service.
Great, thank you. And my last question is a follow-up on everyone else's questions about the value of your integration with Dartmouth. And you mentioned throughout the conversation different areas where you saw savings, and I was hoping you could quantify the total savings you realized through the integration in FY25 and then what you anticipate in 26. And I realize that could be offset by the Epic conversion, but it'd be helpful to see, you cited 400,000 possibly in accounting. You've talked about sharing your CMO, your CFO, your CEO, and some IT savings as well. So if you could quantify all the savings you anticipate, that would be very helpful, kind of in one place. And that's it for my questions.
Thank you, Member Teachout. Just a couple questions. On the infusions, it sounded like your testimony was a big driver was keeping care close to home. Is that fair? Sorry, you have to give an audible response to the court reporter. when did the plan start?
Sorry, I don't understand what you mean.
You said there's gonna be some movement of infusions to Valley Regional Hospital, right?
So that happened before I got here. I think those are parts of the thoughts were really, I think it started when the oncologist that was here was no longer here. And so then it became a question of what can we do that's closer, I believe. And again, I'm speculating a little bit because this happened before my time. So I'll look to Andrew if you know more of the answer.
Yeah, so when the provider left Mount Ascutney, they went to pursue a fellowship up at DH. We didn't stop providing infusion services or turned anybody away. We, kept tried to keep the pipeline going and the infusion suite staffed, and we are continuing that.
And I think there was a nurse practitioner that also decided to go. She was doing that and decided to do palliative care at Dartmouth. And so then we became a question of, I didn't want to have a play. There's high risk, as you know, for those medicines, and it really takes someone who's going to be dedicated overseeing that to make sure patient safety is there, as opposed to someone who can just be a physician or a nurse practitioner that gets signed up set, but not really be responsible for the patient. I don't believe that's good care. And so I think through that is what are we going to do that's the right thing for the patients. So I guess now I understand your question. When did that start? I think losing the oncologist, but then also thinking through, okay, we're not going to have a nurse practitioner. How can we provide what services can we provide safely and reasonably?
That started back in 2024, I believe, with the oncologist moving up to that fellowship.
You know what the difference in commercial price would be between receiving those services at Valley Regional versus Mount Ascutney?
Oh,
No.
no idea.
Okay. I have no other questions. Thank you all for your presentation and for answering our questions. I'll turn to the healthcare advocate for any questions or comments they may have.
Good afternoon. I'll try to keep this to 7 minutes so we can go to 2. Thank you for the presentation and for all the work that you do. And I don't mean to press on a pain point, but give a different angle of questions about the historic homes of Runnymede. You mentioned in your presentation a contract with Sonus Healthcare. When did that contract start?
It started in April of this year.
Okay. And could you quantify how much that costs manually?
Yeah, so it's about thank you, $135,000 a year for management of that.
Okay. Because you also noted in the narrative there's some staffing elements you'd like excluded. It's like $689,000 located in the salaries. Are those paid for by Ascutney or are those paid for by Sonus?
So the only thing we pay for Sonus is $135,000.
Okay.
All the other salaries come out of Mount Ascutney.
Okay.
So it's yes and no. So what had happened is it's a little historically HHR had their own. They did their own. We did a separate payroll for them, and 100% of everything was through their own books, and that's sort of still the case. But when we went onto PeopleSoft, Dartmouth didn't want to do a separate payroll for only 27 employees. That was deemed too small. So there's a whole series of costs that are involved, every time you do run a different payroll and all that. So what they asked us to do was to incorporate the HHR employees under Mount Ascutney's umbrella. So they're now on the Mount Ascutney payroll, but we charge them back to HHR. So we added a layer of complexity. And so it's they're on our expense side, but then there's also other operating revenue that nets it out on the bottom line.
And there were a lot of benefits for the HHR staff. Staffing residential facilities is extremely difficult. The industry at large is in distress with Genesis releasing their bankruptcy news. We have to do everything we can to keep them staffed, and our benefits platform was better than HHR was able to offer on their own. We're able to decrease administrative costs by combining into one payroll, less HR administrative work. And so that really helped staffing HHR. So that's a piece of it. There were new regulations that are just went into place, I think over July 1st, that changed staffing requirements. And so we were required by law to increase staffing. And so part of this expense increase is related to that.
Yeah. So the way we work it from an accounting perspective is, payroll is processed through Mount Ascutney. We pay it, and then we charge back to HHR as a due to from. But we haven't actually pulled any cash back to cover that due to from. So, we may very well just do a net asset transfer to them since we've been covering them from a cash perspective. The expense does end up on their books, but it's skewed because in theory, it's net to zero on our operating margin, but it's in two different places. So, the payback is in the other operating revenue. Using my hands like you can see my P&L, but then the expenses are down below. And because we're held to that 3% expense increase, any additional expense, even though it's netted out to zero overall, just kind of skewed the benchmark.
Okay. I'm assuming you're aware that Sonus is owned by a private equity firm, and I'm curious, since there's a lot of activity in the, senior living, nursing home space, if they've approached you at all about purchasing or taking over control of HHR.
Yeah, Dan, I'm glad you asked that question. I was very concerned about that. So when I started on, I think there were some changes in leadership at HHR and really some concerns about life safety and the safety of residents and the care they were delivering. And thinking through what we had to do with a manager that left the organization shortly after I got here. And so looking at that and talking to some of my partner hospitals, Sal's Pegday over in New Hampshire, that's had a good partnership with us. My initial conversation with them was, how can you help us find someone to manage this? Not, can you take us over? And then it became a question of, how can you help partner with us where we still retain ownership and control, where we are not going to let you run this, but help partner with us to provide the evidence or guidance for policies and procedures. I'm very concerned about the role of private equity in healthcare. I think it's sort of distorted priorities and my priorities on patients. And so I think the arrangement that we have allows us to have complete management authority over that, and they provide consultation and their expertise for making sure our policies and procedures up to stuff, that we're following the regulations through Vermont, that we have the right life safety, quality, and responsiveness to patients and patients' needs, as well as the ability to recruit. And I think we've seen that by reducing our travelers by 75%, by hiring an executive director and being able to post for that position and hire it successfully, and a nurse manager that we were not successful doing that on our own. I said it because it's really important to me, and I hope that you hear that I do not want to have a private equity firm come in and tell us what we can and can't do.
Other safeguards include we continue to own the infrastructure, the management infrastructure like the ERP, the EMR, accounting software, payroll, all that.
And I would say they've been really good, willing partners who came to the table and actually suggested, hey, what if we helped you with the management? And this is what we would do. It wasn't something I asked them. And I kind of wondered cynically, what is it your end game here? Mm-hmm. And I think it's really just to be good partners, and they have been so far. Willing, responsive, willing to accept feedback and push back and allow us to kind of continue to run.
Okay. Thank you. And I'll triage here because I know we're short on time. Just a few follow-ups about your income statement, particularly on the operating expense side. Can you explain what's driving the increases in other purchase services went up from 2.6 to 3.5? Other services went up from 4.4 to 7.8. And it looks like marketing expense, you're asking to have an increase from 16 to 140,000.
Part of it's the shift in shared from to Conifer, so shared services, and also with going live with Epic, our billing staff will now become. We're in the middle of transitioning them to Conifer employees, and that is who Dartmouth uses to do their billing. So it will become a shared service again.
And
registration, all of revenue cycle, pretty much.
And I think when it comes to the marketing, I think it's really important to understand we're not obviously we're not out advertising our services. It's more about communication. So it's thinking about vaccines and vaccine awareness, public health, and screenings that allow us to see health awareness. but also about communication. And I think one of the things that I've learned is that you cannot over communicate. People think, get annoyed by what you're saying or how he is, but us as a hospital system in communicating, they might get like, I'm tired of hearing from Ascutney. But if you under communicate, they think you don't hear. And so I think that's a worthy investment. It's why I wanted to make sure we have some communications as part of our senior team to be there to hear what's happening, but also to be interfaced to the community, so to be out in the community. And I think that's an incredibly worthy investment if we're thinking through some of the priorities we've talked about.
Thanks so much. I appreciate it.
All right, thank you. Is there do you have any other closing comments, Dr. Foster? And after that, I'll just turn to public comment.
Well, thank you. And I know we're short on time, so I'll keep it very brief. Thank you for the opportunity. It's a pleasure to be here. I sincerely look forward to being able to do this every year for multiple years to come. This is an incredible pleasure to be part of this, to lean in to solve really difficult problems that I don't know any other state that's doing this in this way. And I mean that with all respect, because I think it shows that people care deeply about Vermont, care deeply about providing healthcare to everybody in a way that's sustainable.
Thank you very much for your presentation and your thoughtful approach to this challenge that we all have. So thank you. With that, I'll turn to the raise a hand function for any public comment. Okay, seeing none, we can go off the record.
We're off the record.
Right, thank you. We'll take a break till SVMC is scheduled for 2:30. So we can just take a break and we'll return at 2:30. Thank you.
Thank you.